Okay, so thanks for joining me, everyone. My name's Sarah Wassnig. I'm an Australian optometrist, and I'm calling from the New England College of Optometry in Boston, USA. And we're just going to cover today community screening programs and why identifying uncorrected refractive error is so important. So our lecture objectives today. First off, we're going to just discuss why refractive error is so important. This lecture was suggested in the light of the latest data that was released this October by the International Agency for the Prevention of Blindness. In light of this new data, which we'll cover shortly, it's evident that a larger effort is needed across healthcare to access global eye care and get access to communities and individuals who currently don't have access to glasses or the sufficient education in eye care. So we'll look into why including refractive error in community screenings is so important, and if this is something that you're already doing, we'll look into going beyond that to ensure those identified with refractive error are seen by an optometrist or optician, orthoptist, ophthalmic nurse, or whoever is responsible in your health system for providing eyeglasses. We'll also cover how to achieve a successful screening. We'll go over some of the tests. I've included some further procedures in the slides, and my understanding is this will be up on CyberSite after this. So I won't go through all of the procedures in detail, but I have got the procedures listed out in detail just so if you want to go back, you can look over those procedures. And then briefly at the end, we'll just discuss the ethical issues around health screening. So, why are we testing for refractive error and why are we including it in our refractive screenings? I'm going to start off with a question. I'm not sure if there's too many people out there. It is pretty early. It is the day before Thanksgiving here in the US, so I understand if everyone's sleeping in. But we'll start off with a question. What condition do you think is responsible for the majority of the world's visual impairment? So we have age-related macular degeneration, corneal opacity, glaucoma, trachoma, cataract, diabetic retinopathy, and uncorrected refractive error. So I'll give you a few moments to vote there. Okay, so most of you said uncorrected refractive error, which is true actually. The results released on World Sight Day this October by the International Agency for the Prevention of Blindness, or IAPB, pointed out that 49% of global visual impairment was refractive error. So 49% of people who are visually impaired are only visually impaired because they don't have access to a pair of glasses. And a lot of these people are not aware of how to access glasses or that their visual impairment can be solved with a pair of glasses. So 124 million people are predicted to have uncorrected refractive error. So if on our diagram here, each person represents 82 million. These estimates come from Rupert Bourne and Seth Flaxman and the Vision Loss Expert Group, and they were reported in The Lancet this year. Whilst there's a decrease in visual impairment since 1990, so 90 million fewer people are now not experiencing visual impairment since 1990. So our efforts are not going unnoticed. That's 90 million fewer people. But over the last 25 years, two very important demographic changes have happened across the globe. The global population has increased and our global population is aging. So there are significantly more people living beyond their 50s, and this is increasing the number of people who are susceptible to visual impairment, so presbyopia or visual disease. Unfortunately, this means rather than a decrease in prevalence of avoidable visual impairment, it's projected to increase by 5.6%, so an extra 6 million over time will be joining our population of visually impaired rather than that decreasing. So this is going to make it a lot less likely to achieve our global action plan target of a 25% reduction by 2019. So this is the time really to start ramping up our visual screenings. Not only is our population aging, but we are on a whole becoming more myopic or short-sighted, which is unfortunate. So on the diagram here, you can see the orange and the red is the combined prevalence of myopia globally. So the orange is low to moderate myopia, and the red there is high myopia. And as you can see, in 2010, just over 28% of the world's population was affected by myopia. By 2050, it's predicted that 50% of the world's population will be myopic. And also you can see that red section there of the pie is increasing. So that's a number of high myopes increasing. That's myopes over or worse than -5 diopters. So that's a huge concern regarding the health risks associated with myopia. As that high myopia increases, we have higher risks of myopic degeneration, retinal detachment, cataract, or open-angle glaucoma. These estimates here, they come from Professor Brian Holden and his group. So now, in these cases, it's not just enough to prescribe a pair of glasses, and that's why we're going to discuss just throughout our presentation here. I'm just going to keep reminding you that once we have identified someone with refractive error, we really need to then shift them on to someone to deal with that refractive error. So we need some sort of referral base in play. So with these children here that are being identified early, and hopefully they're being identified early with myopia, it's not enough just to give them a pair of glasses, but eye care providers need to now start to take measures to slow the progression of refractive error in these children. So again, this is a great example of why we need to identify refractive error really early. So what's the impact of refractive error? Why is it so important to get people into glasses? Financial burden is a really big issue. Financial burden to communities and countries is a big concern. To have individuals out of work or in limited employment due to their lack of vision is not fantastic. Also, there's a financial burden to individuals who are unable to work, and a depression associated with that, not being able to contribute to their community to the fullest. As we discussed earlier with myopia, high refractive error can result in sight-threatening conditions. Hyperopia, which we haven't covered yet, can also lead to sight-threatening conditions such as Exotropia, which is a type of strabismus, amblyopia, age-related macular degenerations, and conditions such as narrow-angle glaucoma. Lastly, uncorrected refractive error in adults and children has a large impact on the educational potential of our children. This happens in two facets, really. Often children will stay at home to care for a visually impaired family member, or if they're visually impaired themselves, they'll start to fall behind school or fall behind work. The latest Vision in Preschoolers study suggested that early reading skills were significantly reduced in 4 to 5-year-olds if they had moderate hyperopia. So again, another reason to get kids into screening programs really, really early. I really love this picture. It comes from Vision Spring originally, and it was then later reported in the World Weekly. And this lady here, she is Bangladeshi and she's a potter, and with her reading glasses there, she was able to increase her production from 2 pieces a day to 10 pieces a day. So again, this is a fantastic example of someone just with a pair of reading glasses, it really changing their lives and them being able to contribute to their community in a significant way. So, which populations should we be screening? Who should we be looking for? Presbyopes is number 1. With an aging population, we have over 1 billion people without access to glasses, which to me is just mind-boggling. We see so many over-the-counter readers. It's mind-boggling that people are not utilizing that cheap production of glasses and sending near readers out to people. But 1 billion people without access to near glasses. Taking those individuals out of work early. So like that Bangladeshi potter there, if she didn't have that pair of reading glasses, her production would significantly decrease, and she's going to end up working a lot less as a result. Sometimes this is a condition, presbyopia, that the individual is unaware of as well, that they're unaware that it can be solved by glasses. So they're aware of them losing their vision, but sure that glasses can make all the difference. So education in the community is really important in improving these rates of presbyopes who are uncorrected. That's educating community leaders as well, and starting with community leaders, and then helping them disseminate the message throughout the community. Women, globally, for every man who is visually impaired, there are 1.07 women who are visually impaired. So they're more likely. There's a number of factors that contribute to this gender imbalance. Life expectancy of women is a lot longer. So in the case of refractive error, we're having a lot more presbyopic women out there. And coupled with that, we have a higher risk of sight-threatening eye conditions as women are getting older. Women are at a greater risk of certain eye conditions, and also in some countries, women are disadvantaged when it comes to accessing health services due to socioeconomic and cultural factors. So making sure that when you're out in screening in communities, that you're not only seeing the people who are working, but you're also seeing the people who are in their homes and working from home. Lastly, a really important group is children. As we mentioned earlier, refractive error limits educational potential and work. Also, children are less able to identify themselves as visually impaired. So they do recommend a yearly screening of children between 3 and 6. The reason is I know I can compare, I can discuss with other adults what my vision looks like and what I can see, whereas children have less of an idea of what everyone is able to see. They don't know anything different, and so they just assume that everyone can see just as well or just as worse as they can. So it's really important to make sure that kids, even if they say they're seeing pretty well, to make sure that kids are being seen. So lastly, why do we need screening in communities? Why doesn't everyone just go to the hospital, come into the big city? And the reason is that a lot of remote communities have limited access to big city hospitals where most people in most countries are working in healthcare, either due to limited transportation or not being able to take the time off work to get to the hospitals. This is a really big concern that limits their access. If we can get out there, then we can solve that problem. It's also difficult to self-identify if you don't have the education, if you don't have the facts about what eye conditions there are out there, then you don't know that you need to go and get your eyes checked and get a pair of glasses. So let's establish a community screening for refractive error, and let's find out what we do first. We need to start off by identifying and speaking with local leaders in the community about the importance of screening for refractive error, and also gaining that trust with those community leaders. Once it's supported in the community, we need to get the word out for the visit. We need to write a list and collect the necessary equipment, and that includes both children and for adults. You'll see here this lady is holding up a child-specific eye chart, so you need to make sure you have the materials necessary for testing children and adults. We also, before we get out there and into the communities, we need to establish a clear referral criteria. Now, this referral criteria will depend on the hospital or on your group who is looking into sending people out for community screening. But it's a very good idea that anyone who is out there screening in the field understands who needs to be referred and who is happy and who we're happy to stay at home. Lastly, there needs to be a referral process in place. We need to, once we've identified those people with visual impairment, we need to know how they're going to get their glasses. Will there be someone on site with frames and click-in lenses, which are fantastic? A lot of people are out there with ready-made lenses and ready-made frames. Once we identify what the refractive error is, they can grab the lenses, grab the frame and click it in. We have some people out there in community screening who have glasses that they can change the thickness of the lens, and they can snap off that piece that's changing the thickness of the lens. So we've got a lot of different ways of supplying lenses on site. Another way is maybe the person will be sent to hospital, particularly if you find something other than refractive error causing low vision. And so maybe the person needs to go to hospital to collect their glasses or have an extended examination. And if that's the case, how are you going to get those people there? Are you going to take them straight away? Are you going to come back and pick them up? And then you need to think about how long they're going to have to be there and bring them back again to their community. Another option is, are you going to take away the results? Make sure that if you are doing that, you're recording people's names correctly. You're going to take away the results, make up the glasses, and then bring them back in maybe a month or 2 months' time. Look, it doesn't matter what your plan is, just as long as there's a feasible plan in place. Having a plan in place before you leave is really important. Deciding on what the referral criteria is and what you're going to do with those patients on the spot is never a good plan. One of the biggest concerns is there's not enough available ophthalmologists to send out to communities for extended periods of time. They're needed in hospitals, they're doing a lot of surgeries, and so the people we need to call upon in providing vision screening are allied healthcare providers, optometrists, orthoptists, ophthalmic nurses, etc. Whoever you have that are providing glasses in your community or in your health system. Another way is to reach out to community leaders and to have these professionals train community leaders whilst they're there as well. This comes from the most recent data released by IAPB, again on their visual atlas. There's a link down the bottom where you can access the visual atlas. And here we see there are a significant number of ophthalmologists working in countries that have a lower incidence of uncorrected refractive error, and that is significantly less in countries that have a higher incidence of uncorrected refractive error. So up the top there, we've got high income countries, and you can see ophthalmologists up there, they're circled. There's quite a few per, I think it's per million population. The countries in blue, green, or the regions in blue, green, orange and yellow down there, you can see have a significantly less number of ophthalmologists. So ophthalmology is already very stretched when it comes to providing services to the community. You can see here now, if we compare the number of optometrists and allied ophthalmic personnel from high-income countries or countries with lower incidence of refractive error, if we compare them to countries of high incidence of refractive error, we can see that the countries that have a lower incidence of refractive error have a large number of supporting staff. So optometrists, ophthalmic nurses, orthoptists, people helping identify people with refractive error, with eye concerns, eye conditions, identifying those who need to be sent to ophthalmology, and then dealing refractively with those who don't need to be sent to ophthalmology. And so this is one of the things that we really need to focus on in building our capacity to treat patients, is building the number of allied ophthalmic personnel in our hospitals. The Vision in Preschoolers study did a study in 2009, and they compared trained nurses to trained lay people and their ability to administer screening tools successfully. I do want to stress that this is in children, this study here. They found that both groups were able to correctly identify up to 80% of children with at least one vision disorder. So that's pretty impressive. That's quite high. They did this with autorefractors and visual acuity charts. Again, I want to stress that this is in children, so it can't be applied directly to adults, but let's consider that maybe adults are a little bit easier to test than pre-verbal or just newly verbal children. So we can see that this would also be quite successful in adult screening as well. So we need to start increasing our supporting personnel by increasing the training of lay people as well as those supporting ophthalmology through allied health. So allied health professionals getting out there and training community leaders, teachers, government officials, the people who are really setting an example in communities. In 2004, the Vision Preschoolers group looked into the most successful tools for assessing refractive error. For trained licensed allied health professionals and ophthalmologists, retinoscopy is still the most accurate way of identifying refractive error. But if we're looking into recruiting some more community members, they looked into two handheld autorefractors, the Retinomax and SureSight, were the top autorefractors at the time that had the best sensitivity. I want you to keep in mind again that this was over a decade ago, so there has been a lot of changes when it comes to autorefractors, but this gives you a good start. We're going to discuss the most successful tools for assessing visual acuity, but they also looked into that as well. So first, let's start with what are we going to include in a visual screening? We're going to do visual acuity and retinoscopy. Based on this study here, our most successful tools are autorefractors, retinoscopy, and visual acuity charts. We have some other tests that you can include. We've got distance cover test and near cover test, which is going to help you identify a phoria or atropia, extraocular muscle testing, which is going to help you identify a muscle or nerve palsy. We've got Bruckner, and that'll help you identify visual acuity and refractive error. This is actually something that we will go into a little bit of depth because it's quite a helpful tool. Near point of convergence and stereopsis will give you some idea about binocular vision concerns. We have confrontation fields and facial fields to help assess visual fields in adults. We also have color vision and pupil response that can be assessed as well. The tests that I've listed under other tests, these are tests that either require equipment that is a little bit more advanced or requires training that's a little bit more advanced, but these can be something that can be taught to lay people, but you just need to make sure that they understand what the test is for and that they practice a lot, and at the beginning at least being supervised by the allied health professional. What equipment do we need to take if we're doing visual acuity and refractive error? We need to take a visual acuity chart. This can be tumbling E, you can use ETDRS letters or LEA symbols, preferably a logMAR chart, and you need a tape measure to make sure you know what distance you should be testing at. So we're going to go through this in a little bit of time. Also a near visual acuity chart for testing your presbyopes, and Occluder if you're not trusting that people won't peek through their fingers there or look around their hand. If you're an advanced trained professional that's joining the screening, then your diagnostic kit is really valuable, bringing your retinoscope, your retinoscopy racks, or if you don't have retinoscopy racks available, loose lenses, your direct ophthalmoscope for Bruckner and checking the health of the eye, and your transilluminator or pen torch just for observation and checking pupils and Hirschberg. If examiners are less trained, such as community leaders, then an autorefractor is necessary. So we want to first start by asking the patient important health and visual questions. We're going to ask if they've had an eye test before, if they have had glasses or own glasses, if they've worn or have worn contact lenses, if they have any concerns about their vision, if they have anyone in the family that has any visual history, if their general health is pretty good. So we're looking out for big ticket items like diabetes, high blood pressure, heart concerns, anything that we would be thinking about referring. And also a really good idea is to ask about someone's occupation and their daily tasks. It's one thing getting someone a pair of glasses, but if they don't suit what this person does on a day-to-day basis, then they're not going to be used, and we haven't actually addressed this patient's concerns at all. If your patient's a child, you want to ask the parent what their concerns are, and ask the child, do they like reading? Do they need to use their finger when they're reading? Do the words move on the page at any time? Ask them what their favourite subject is. That might give you some idea about what's holding them back in school, and also helps you bond with the child. And can you see the board at school, whether that's a whiteboard or a blackboard, or in some cases an electronic board. If a device-based screening is chosen, so you have community leaders mainly doing the screening, then we need to choose an autorefractor. we have the Retinomax and SureSight Vision Screener, and they were really identified by the VIP study and Cotter in 2015 as superior devices for identifying refractive error in children specifically. We also have the Welch-Allyn Spot, which is just new on the market. It's recently been added to the recommended screening devices list. We also have the Plus Optics Vision Screening Device, which has been labelled as acceptable at this stage. Also, interestingly enough, there is a lot of cell phone technology coming about. So watch this space. There's everyone we know has a cell phone. And so if we can utilise this technology and include it in autorefraction, that would be fantastic. So you can see down the bottom here, this lady is using a virtual reality headset and the phone that's been provided there to find out what her refractive error is. There's also an eye scan app. There's a lot of different technologies out there. They're not as, they're probably not up to scratch as much as we would like, but it's definitely something that is worth keeping an eye on. There's a lot of advantages and disadvantages to using autorefractors. The advantages of autorefractors is it's quick. You can get through a lot of people in a short amount of time. It requires minimal cooperation from the patient. It really does require a lot less training for the person administering the test. It's portable and it's great for pre-verbal children or pre-literate children. So if you can't get that visual acuity response, it gives you at least a starting point of what this child's refractive error is. Disadvantages is it's a limited ability to detect strabismus and higher hyperopia in some of them. So there's been a few studies out there that says that they haven't been quite as accurate in some cases. The cost of the instrument, these autorefractors can cost quite a bit. They require electricity or batteries to work, so you need to make sure that you have a generator or them charged or enough batteries for the time when you're out wherever you are if they don't have electricity. And it may be less reliable in children, and this is due to active accommodation or also perhaps a less stable fixation. Rather than them looking where they need to be looking, they're more inclined to look around. And so that could contribute to an odd result or an unreliable result. When thinking about autorefractors or thinking about refractive error, obviously as your referral criteria becomes tighter, it's going to increase the number of patients that you send off. Which means that you will increase the number of patients that you correctly identify as needing to be referred or needing glasses, but it will also increase the number of patients who you've sent off that were unnecessary. So that's something to consider when you're thinking about your referral criteria. Okay. Just so I can have a little bit of a break and a drink here, we're going to add a question in for the audience and just to wake everyone up a little bit. So once we identify the refractive error with a retinoscope or autorefractor, who do we refer? We have a question here. What is the expected refractive error for a 1.5-year-old toddler? So is it -1, -2? Is it less than +2 or less than +1? Yeah, it is less than +2. So testing an adult is a little bit easier because it's easier to identify if they can't see, and we can correct that pretty well. Children are a little bit more complicated as they're expected to have a small refractive error from a young age. So let's see if I can move on. Oh, there we go. So this is just a little table giving you an idea of the refractive error that we would be looking for. Notice how it says down the bottom anisotropia less than 1. So we always want to make sure that there is less than a 1 difference between the two eyes. But you can see that kids, when they're born, they start off relatively hyperopic, and as they get a little bit older, that hyperopia decreases. So you need to understand, or your screeners need to understand, if they see a 4-year-old and they're 1.5 diopters of hyperopia and it's even in both eyes, and that's pretty good, that we're just going to leave them be. However, if you had a 45-year-old with 1.5 diopters of hyperopia, you might start finding that their vision in the distance starts to decrease depending on their accommodative level. And so you need to explain to those who are screening that there are different standards or different referral criteria for different age groups, and that a little bit of hyperopia is absolutely fine. Children, as we mentioned before, they're a little bit more complicated, so they're at a higher risk of amblyopia. So amblyopia is a condition in which less visual brain space is dedicated to one eye, and that limits that eye's visual potential. So we need to look for concerns regarding amblyopia. One of those concerns is the refraction normal? So if we go back, if this child is 4 months, is it above 350? We also want to look to see if the vision and refractive error is equal. So again, referring back to that anisymmetropia, if you have the right eye that is a +3 in that 4-month-old, which is fine, but the left eye is a +6, that's not fantastic. That +6 eye is going to start sort of drifting away and turning off and sending less signals to the brain there. So we need to make sure that we correct that child so equal signals are going to the brain and the eyes are sharing that brain space. One thing that you'll find both with retinoscopy and when you're doing your autorefractor is you'll be able to see if the media is clear just by virtue of the fact that the reflex will look a little bit different. This is for both children and adults. So in adults, we're mostly probably looking for cataract in older adults, but in children you'll be able to see if the media is clear, if you've got a congenital cataract or if there's a tumor or something in the vitreous. You may also, whilst you're doing these tests, observe if the eyes are misaligned. So if you're not doing any tests that specifically address the misalignment of eyes, so strabismus, then having that still on your piece of paper that the examiner can check off or tick off and say, yes, I've noticed that something's not right, that right eye isn't looking straight ahead, is a really good idea, because sometimes they might find during their autorefraction that one eye isn't looking at them and they can see that. So we've gone over handheld autorefractors and retinoscopy, and they're the most successful tools for assessing refractive error. The most successful tool for assessing visual acuity is a visual acuity chart, and just getting someone to go through the steps of different levels of vision. There's a couple of things that we're looking for in visual acuity charts. Here we have a few pictures. So up the top there we have a Lear chart, so Lear symbols. You can see that there is a box around them, and so making sure that if you are showing a single line acuity chart, that they have crowding or crowding bars. So that box is referred to as crowding bars. You can see the two charts there, the tumbling E and the Snellen chart there. You can see both of them have the full chart, so they've got other symbols all the way around them, and again allows us to introduce that crowding. The reason that crowding is really important is we want to give a more realistic idea of visual acuity, and that would include visual attention. In our environment, there's a lot of things competing for our visual attention. So if we have something on our chart that is competing for our visual attention, it gives a more realistic measure of visual acuity, and that's particularly the case in amblyopia. You can also notice that those two charts, they're logMAR scaled, and the chart up the top where the Lear symbols are being shown, it's calibrated for 5 or 10 feet. And so you want to be able to move that chart back and forth just to get an idea of what the visual acuity is. If they can't see anything on the chart, you can move closer and you can do the calculation to work out what that visual acuity is. So when we're checking visual acuity, first we're going to ask the examiner to We're going to ask the patient to cover one eye. If you're going to use an occluder, that's fine. If you're going to use the patient's hand, just making sure they're not peeking through their hand. The examiner is going to point to the visual acuity symbol, so the letter or the Leah symbol or the tumbling E. You're going to make sure that you're not covering that symbol and you're not covering the letters around or the symbols around it. You're going to start at the top of the chart and ask the patient to identify the first symbol. If they easily identify it, then you want to move one line below. If the patient's squinting, leaning forward, or if they're starting to get incorrect answers, then you want to test that entire line above it. So we might start from the very top. They tell us that's an E. We go down, we pick one letter, they tell us that's a D, and that's correct. We go down one and they're a little bit hesitant and they're not quite sure what that letter is. Then we're going to go up and test the whole line that they got right just previously, that line with the D in it. So we're going to continue moving down the chart until the patient reads about 3 or more incorrectly, and that's your endpoint there, that's your visual acuity. One big thing when you're doing visual acuity is maintain a positive attitude when someone gets a symbol wrong. Going, ooh, not so good is not a great way to build their confidence. And this is also really important in children to keep them engaged, just so they'll play the game and they'll correctly identify the symbols. So some pearls of wisdom for visual acuity testing. It's a good idea to confirm that they understand what the test is. So if you've got a tumbling E, that they understand that you want to point in the direction that the E is facing. If you have a Roman alphabet chart, that you just want to make sure that they are literate, they understand the Roman alphabet, they can identify them. And you also want to confirm, if you're using Leah symbols, that the children can name each of the symbols. They can name them whatever they like as well. If they think the house looks like a triangle, just roll with that. This is not your time to teach them what a house looks like or teach them what a triangle looks like. So just whatever they name them is fine, and just continue moving on. So you want to continue building their confidence. You don't want to shut them down and say, oh no, that's not a square. So keep building their confidence. So whatever they name the symbol, that's fine, as long as it's consistent. You want to observe the patient and not the chart. And we find our students do this a lot. They're watching the chart and making sure they're getting all the answers right, and they're missing the patient leaning forward or squinting or peeking around their occluder. So you want to make sure that the patient isn't doing any of that. So you can remind them to sit back and relax, to stop squinting, you can replace their occluder. It also maybe gives you an idea about where their limit of visual acuity is. Also, they have these fantastic glasses from Good Light here. You can use opaque glasses, and this allows one screener with a child to have the child wear a pair of glasses with an occluder, allows the examiner to be at the other end pointing to the symbols and not worrying too much about the child looking around their occluder or their fingers. So these are purchased from goodlight.com. You want to test one eye, then you want to test the other, but you might start binocularly testing in children or even in adults who are a little bit hesitant, and give them some larger letters and some larger symbols to start off with. And you want to test with the patient's glasses on first. So if they're wearing glasses and they pass, then they're fine, they're fantastic. They don't necessarily need to update their glasses for that distance. But if they're failing, then we have a good idea about how much we might need to change that prescription. So what's an acceptable visual acuity for a 4-year-old? So I'm going to pose this question to the audience here. We have 20/40, or for those playing at home, 6/12 at 5 feet or 1.5 meters. We have 20/20 or 6/6 at 5 feet or 1.5 meters. 20/60, 6/12 again at 10 feet. Oh, sorry, that should say 3 meters where it says 10 feet. And 20/60 at 5 meters. This one's a little bit of a tricky one. I like that we got 50-50. So with adults, it's a little bit easier. They should be seeing 20/25 at distance and at near with both eyes. Maybe even a lot better than that, but 20/25, it should be at least someone who doesn't have any sort of refractive concerns. They should be at least be able to achieve that. But in 3 to 4 year olds, you're looking for about 20/50, if they're getting less than 20/50 at 5 feet away, or if they have a 2-line difference between the two eyes, then we want to start thinking about referring that child off. We go up a line if they get less than 20/40, so we're improving by a line at that 5 feet, at that 5 foot mark. And then older kids, we should be expecting them to get about 20/30 minus 2 or so, or 20/30 at about 10 feet away. So we can also afford to start moving back a little bit with those 6-year-olds. Notice that with children, every time we're looking for that 2-line difference between the two eyes. So if there is a 2-line difference, then that should set off warning bells that maybe this child is suffering from amblyopia and we need to refer that child. So visual acuity conditions, this is adapted from the American Academy of Pediatrics. You need to mark where your chart is. So you want to take a measuring tape or something like that so you can mark where 10 foot is, or 5 foot, that's 3 meters and 1.5 meters on the floor. You need to have a clean chart with a white background, so you want to make sure that it's nice and clean. You want to make sure that that chart is stored in an area, in a box that is nice and clean as well, just so you have really good contrast. You want to place the chart at eye level, so either if someone's holding it, you want to make sure it's eye level with the patient, or if you're pinning it up or taping it up, you want to make sure it's eye level. And you want to make sure you're testing in good lighting conditions, so minimize the shadows around the chart. Near visual acuity in adults, we're going to ask the patient to hold the chart at their reading distance. This is a little bit more realistic. You can also assume that most adults over 50 will have some difficulties at near, with the exception of low myopes. So if this person is reading 20/20, the prescriptions that I've listed there for each age group, it's a good starting point if you want to start prescribing over-the-counter readers. So that'll be a good starting point for that patient there. That's just based on the expected level of accommodation. So a few other tests that we could check to see, so if we have low visual acuity, if we want to make sure that low visual acuity is actually due to refractive error, one of the things that we could do is pinhole, a Bruckner test, and retinoscopy, which we're not going to go through today. We're going to leave that to a later webinar, which will be, I believe, presented in February by Dr. Daniel Bastian, also from the New England College of Optometry. So tune in for that. So an occluder is an opaque disc, so you can see that this one on the left-hand side is held up like a pair of glasses. The one on the right-hand side is held up like an occluder, and there's a small hole through it where the patient can look. And it's a simple way of focusing light, sort of like a pinhole camera, and it temporarily removes the effects of refractive error. So if you have refractive error and you're seeing a little bit blurry, and you should be able to look through that pinhole and see a little bit clearer. If your vision is improving, then you know that it's a refractive error concern. If you hold that occluder in front and your vision isn't improving, then you know that this is a different type of concern. We're thinking more ocular disease now, so we need to make sure that patient is being referred before looking into a pair of glasses. So we have Bruckner here. This is a procedure done with your direct ophthalmoscope. You hold it at about sort of 50 centimeters or so, about 50 centimeters to a meter. And sorry, it says transilluminator. That should say direct ophthalmoscope. And it's done binocularly. So you're dialing in, you're a meter away, you dial in your +1 into your direct ophthalmoscope, you look through the hole to observe, and you're going to observe the patient's red reflex. If the patient is an emmetrope, then in the center there it should be bright red. If they're myopic or hyperopic, you're likely to see this little crescent, this little light crescent. So you can identify if what type of refractive error it is, but you can also see if there's a bit of asymmetry between the eyes. Maybe one has a small myopic crescent, one has a large myopic crescent. And also you'll be able to identify if there's any strabismus or media opacity, if the reflex coming back is completely opaque or a whitish color. So we did have some questions in here, but for the sake of time, I'm just going to go through some of these for you. So you can see here that this child is myopic. In fact, this child's spherical equivalent is minus 2.25 in the right eye and minus 1.25 in the left eye. So you can see the big difference between the two crescents there. I wanted to pop this one because you can see that there's quite a bit of asymmetry between the two eyes, but you can't really tell what kind of refractive concern this is because the refractive error is so high. So this is a minus 11 in the right eye and minus 13 in the left eye. Here we can see our hyperopia. We have plus 3 diopters in the right eye and plus 4.5 diopters in the left eye there. So you can see those hyperopic crescents. You can see they're fairly similar. Maybe that left one's a little bit larger. With this young lady here, you can see that the right eye is deviating, and in fact, this patient here has a 30 prism diopter deviation, and so you can see that you get this nice red reflex in one eye, the eye that's looking at you, and the eye that's turning away, the eye that's turning in. You can see that that eye gives like a nice sort of white sheen to it, and so you can tell that then it's not focusing and looking at you at the direct ophthalmoscope. This little one here, both eyes are straight, but you still get that white sheen. And the reason we're getting that white sheen is because we've got a bigger concern that maybe this child has some sort of opacity in their media, maybe a cataract or a tumor or something like that. So the light is hitting that opacity and coming back to us white. And you can tell that this is more of an opacity issue because you can see that the child is looking relatively straight. So after we've done our visual acuity and our refractive error, this is just a small list. It's not an absolute list, but it's a good place to start, particularly in children, if you want to add some additional tests apart from the pinhole and the and Bruckner. We've got Hirschberg, which can be done with a transilluminator. I'm just going to quickly show you that. So this is about half a meter away, and you're going to compare the corneal reflex position of the focusing eyes. If there's one eye that isn't focusing, then you'll see that the corneal reflex is not in the center. Use, in this case, your transilluminator, and this is done binocularly. This is just a schematic here of what it looks like. So the normal, you've got those two central corneal reflexes. You've got your exotropia up the top right-hand side, and you can see that little reflex there is no longer in the center of the pupil, but it's a little bit more nasal. And in the esotropia, it's a little bit more temporal. And in hypertropia, you can see it's a little bit more inferior to the center of the pupil. So again, for the sake of time, we'll just quickly go through. Actually, no, I think we've got a little bit of time. Let's pose this question. What kind of deviation do we think this is? So we have exotropia, exophoria, esotropia, or esophoria. Yeah, beautiful. It's an esotropia, and you can see actually it's pretty dramatic, and so you can see that eye turning in, but you can also see that Hirschberg and that little corneal reflex here just off to the temporal side of the pupil. What about this one here? What does everyone think is going on here? Exotropia, exophoria, esotropia, or esophoria? Beautiful. I love actually that we have a little bit of a split there. It's a little bit easier. It's a little bit harder to tell. So our fixating eye is this eye here. This is our eye. It's looking at us. This is in the center of the cornea here. And you can see, oh, sorry about that. And you can see that this little reflex is just off to the nasal side of the center of the pupil there. So it does get a little bit harder to tell an exo from an ESO, but this is a really good way of helping you out there. Also, some general observations, like I mentioned before, having that in your, having a spot where your examiners can write down if they see nystagmus, so some shaking of the eyes, if they see one lid drooping, if their head posture is to the side, if there's any discharge, if there's any corneal clouding, if there's a red eye, lumps or bumps that look unusual. If the person wears glasses, it would be great to have that on your piece of paper to note that down. And if there's any behavior that anyone's concerned about, such as squinting, or maybe the child isn't developing how the parents expected. Included in these observations, you could also include pupils to a small extent if the examiner is just a layperson who has been trained. So if you don't want to put too much pressure on them there, but you can ask them if the color between the two irises are the same. You can ask if the size of the pupils look about the same, if they're positioned centrally, and if they've noticed any response to direct light. Or if they constrict with the fellow pupil. So it's a little bit more advanced, and you don't want to put too much pressure on people who are not trained to identify certain conditions, but this is something that you can start sort of introducing as your screening process goes on. So this is going to be our last slide here. I'm actually not going to go through it. I just wanted to make a point here that I've put in cover test, EOMs, and near point of convergence. So in the interest of time, I'm not going to go through these tests, but I have outlined the procedures for each of them just to get you started on reading up on the procedure. We hope to be uploading instructional videos on tests, and along with that have written instructions as well on CyberSite over the coming months. So keep an eye out in the courses of refractive error. At the moment there's a couple of manuals in there, but keep an eye out there. We're hoping to increase our impact on CyberSite a bit there, and pop in some instructional videos. So that will include cover test and EOMs and MPC. So we've just got some instructional slides here. I'm just going to finish up here just as we're winding up, and if you have any questions, you can start sending them in. But I just want to quickly pose to the group that there are a lot of benefits of screenings, and I've just spent the last sort of 50 minutes or so convincing you that heading out there to screen for refractive error is really important. But also there are a lot of limitations to screenings that you should just be aware of. There is often a cost to the patient and to the government or the hospital if they're needing to supply equipment. So that's something you need to consider as well. What equipment do you need? What's the minimum equipment that you need? Also, to the parent or to the patient that needs to then be referred to the hospital, what kind of cost are we looking at for that parent or for that patient? We need to take into consider language and culture. You need to make sure that you are entering a region that either you have a very clear understanding of the cultural background, or you are with someone who does understand the cultural background and someone who can understand the language. Screening goes a lot smoother if you can speak the same language. I also want you to think about that you will end up referring a lot of people who didn't need to be referred, so that's going to be an additional cost to that parent or to that patient that was unnecessary. And you will also end up not referring a few people who did need to be referred. So there'll be some people who are missed, and there'll be some people who are sent unnecessarily. We can't really do a lot about that, although we can try to train our personnel as best as possible and have very clear referring referral criteria, but just keep that in mind. There will be both times where you're unnecessarily referring, or you're referring or you've missed someone. To avoid the number of people that you're missing with refractive error, going back to that same area every year or year and a half is a good way of addressing that. So that comes to the end of our lecture today. I hope that it was informative. I hope everyone's enjoyed it. If you have any questions, please feel free to send them through. I'm not quite sure if I can see that. No, I don't think I can.
Thank you, Dr. Wassnig. We don't have any questions yet, but we have about 5 minutes. If anyone wants to type those in, do you mind waiting 5 minutes?
Absolutely. No,
okay, perfect.
Certainly hope it's a lot nicer weather wherever everyone else is than it is here. It's pouring rain, it's quite cold. Looks like it's going to be a wet Thanksgiving, everyone.
So I don't see any questions coming in. There were 4 questions asked at the time of registration. Do you want to just, I can share my screen and want to just go through those quick? Okay.
Absolutely, absolutely.
Can you see my screen?
I can.
Okay, so if you want to just talk through these, I think that should be good.
Yeah, so blurry vision on one side of the eye. Look, that's definitely something that you want to refer off. I think we're talking about a visual field concern. So including confrontation fields is a really great way to address visual field concerns. That actually sort of prompts me to make sure that we pop up instructions on confrontational fields and facial fields on cyber sites. We'll pop up some instructional videos on both of those procedures, but that's definitely something that you want to refer for to ophthalmology. Undetected refractive error caused by redness and itching. Again, that's going to be something that we want to refer to ophthalmology, or depending on the country that you're working within, you might refer that to your ophthalmic nurse or your optometrist to deal with. Once you have addressed the redness and the itching concern, then you can look into refractive error and see maybe if visual acuity improves a little bit once that redness and itching has died down. How far is the refractive error reliable for school screening based on accommodation in a young age group? Yeah, look, that's a really big issue. When we're doing retinoscopy, we try to get them to look as far away as they possibly can, to have someone really interesting at the other end. So I usually get my students jumping up and down. I encourage them all to learn to juggle, and the worse they juggle, the better, the more entertaining they are. And so having someone as far away as possible helps relax that accommodation as best as possible. You could also introduce a fogging lens if you were a bit concerned if the pupils were small. I'd be thinking there's a lot of accommodation happening there, and I'd be thinking about hyperopia. Warning bells would be going off of, I'm not seeing a lot of hyperopia, but the pupils are so small that I think that this child is accommodating quite a lot to see clearly in the distance. So that would just send warning bells off. Unfortunately, with smaller pupils and your autorefractors, I think some of them have less reliability when a child has small pupils. And so that's something you want to consider with your autorefractor. And also with your autorefractor, this might be one of those moments where you're not sending off as many kids as you need to. If they have very high accommodation, you might not catch that really high hyperopia with an autorefractor. Practicality of using cycloplegics in an outreach program. Look, I think that if you have someone on site, I think that that's definitely a possibility if you have someone trained to prescribe cycloplegics on site. What you need to make sure though is that you're doing a thorough test of the angles. You just don't want to pop in a drop and find out that you get yourself into a bit of a pickle with the angle closing. So you just don't want that to happen, because you're in a situation that you don't have immediate access to the care that you need to reverse that or to alleviate that. So that is something that you want to consider. But if you, particularly if you have a handheld slit lamp, or if you're doing a pen torch test, a light test from the side, and you can see that the angles are clearly open, then I think that this is something that you could definitely incorporate if you have someone trained in the administering of drops. An acceptable alternative. Look, I think. If you're thinking about in terms of kids, again, like we were saying, you could fog the child a little bit, so making sure that pop it on a trial frame, make sure that their accommodation is relaxed using plus lenses or a plus over their current prescription. In terms of dilating for looking at eye health, then that's something that you want to sort of consult with your ophthalmologist on. Hopefully you have one ophthalmologist on site doing visual screening as well, and screening those who need to be referred. But if that's not the case, then you need to get those patients off to ophthalmology somehow.
We also have one final question if you want to just answer that, and then that should probably be good.
How can we do stereopsis? Yeah, stereopsis is an interesting one. It's going to give you more information about how well the child is seeing out of both eyes and give you some information about their binocular vision. It may not be your major concern though in screening, so I think it's a really good idea to have a clear set of objectives when you go out for your visual screening. So I want to identify anyone who has refractive error, anyone who has strabismus, and you may or may not include binocular vision in that. So stereopsis is an easy way to assess binocular vision, but it's not always very reliable. It just maybe gives you a clue as to how well both eyes are working together. You'd be better off looking into or adding tests like your near point of convergence or your cover test to assess binocular vision and binocularity, and if the eyes are aligned, and if they're working well together at distance and at near. You could also add into that a Worth 4 dot test, which is would check for suppression at distance and near, and you can get Worth 4 dot torches and with your red-green glasses on for the child. So we will include on Cybersite over the next few months, over the coming months, all of those procedures and instructional videos on those. So we've convinced our students to act as patients for you and as doctors for you, to show you how we administer those tests. So keep an eye out for those tests. But if you're looking for binocular vision, adding stereopsis, adding Worth 4 dot and adding NPC, and also adding cover test, I think is a really great start.
Great. Thank you so much, Dr. Wassnig.
No, thanks for having me. I just want to point out that we've got lots of optometry webinars coming up, and to also keep an eye out on Cybersite for our instructional videos and things popping up as the months go on, as we get into 2018. Thanks, everyone. Thanks so much.
Have a good day, everyone.